Our next speaker is Dr. Dosimo Gumbi. Dr. Dosimo Gumbi is the medical director of Duchess International Hospital, Lagos, Nigeria. He's also the assistant professor of medicine, University of Alabama, Birmingham, Montgomery Regional Campus. Dr. Gumbi, go ahead with your presentation.
Good evening, ladies and gentlemen. Thank you very much for that introduction. We can see here that I will be speaking about the screening tests for colon cancer and specifically including the test that we do at Duchess International Hospital and an overview of the services that we offer there. Well, these are the various screening tests that are available for colon cancer. We can see that colonoscopy is the most sensitive for detection of colorectal carcinoma, which is to say it accurately diagnoses colorectal carcinoma and does so early at a very high rate, 95% detection ability to correctly detect 95% of people who truly have colorectal carcinoma. And you can see, and a colonoscopy is an endoscopic procedure where, and we'll be talking about this further on. The other speakers will be talking about this further, but where the doctor looks into the bowels, in this case with an endoscope, so they can actually see what's going on and remove polyps, which is the way colorectal carcinoma starts. That second test seen there is fecal immunochemical test, and it detects human blood specifically, compared to the fourth one, which is GWAC, fecal occult blood test, the fourth one, GFOBT, which detects blood from any animal, human or another animal, which is to say, if you were to eat red meat, it will come back positive, even though you yourself are not bleeding. And this accounts for the difference in the accuracy. You can see the FITS test, that second one is a bit more accurate than the GFOBT, which detects blood, whether human or otherwise. The third test there, CT colonography, is a special CT scan where specialized software is used to recreate a two-dimensional or three-dimensional view of the colon, depending on the software available. So you can see that's pretty accurate as well. The last, and by the way, I should say that the FIT test is a test looking for human blood in the stool specifically, and the fourth test, GFOBT, GWAC, looking for any kind of animal blood in the stool. The fifth test, FIT DNA, is also examining the stool, and it not just looks for evidence of human blood, but also alteration in DNA, so making it very accurate indeed for detecting cancer. So it's superior to just the FIT test, which is just looking for human blood. Next slide, please. So, and this slide tells us the bottom line effectiveness of these tests in preventing deaths. That's really what's important, right? These fancy words, sensitivity, specificity, positive predictive value, all those kinds of things. Bottom line, that's not really what's important to you and your loved ones. What's important is, what prevents us from dying early? That's what's important. So on the left-hand column are the various screening tests that we've just talked about. On the right-hand column is the death prevented. Let's say we follow everybody from age 40 and we do the respective screening tests. How many deaths per 1,000 40-year-olds would we prevent? How many deaths from colorectal cancer? Everybody dies of something eventually, but how many deaths would we prevent from colorectal cancer? And you can see they're actually, bottom line, they end up being, they're pretty similar, but of course you have some variation. And For colonoscopy, we prevent between 22 and 24 deaths per 1,000 40-year-olds. 40-year-olds followed until they die, whether they die at 50, 60, 70, 80, 100 or more. How many colorectal cancer deaths do you prevent per 1,000 people? For the FIT test, which remember is the test looking for human blood in stool, you prevent 20 to 23 deaths per 40-year-old. 40-year-olds are followed for life if you use that test. The third test, which is the CT scan imaging the colon using special software to recreate the colon, we're able to prevent 16 to 24. You can see there's more variation. This variation, and no doubt, depends on how well that test is done. So you can see it can be excellent, but it can be not so good. I think it depends on where you get it done, undoubtedly, and who is reading the test. GFOBT, which remember is looking for animal or human blood in the stool. So less accurate than the FIT test, but at least theoretically less accurate. But bottom line is it prevents the same number of deaths. FIT DNA, which is superior because that's looking not just for blood, but for alteration in DNA. So it's a sort of superior way of looking for cancer, and yet it's only marginally more effective in preventing deaths. Next slide, please. So age for screening. So this slide speaks to average risk. That's to say people who do not have a significant family history of colorectal cancer. So for people at average risk, these are guidelines from the United States, but this very much applies to us as Africans and Nigerians and African Americans, because it was the colorectal cancer incidence and deaths in Black people that drove the latest changes in these screening guidelines for all Americans. So again, for people at so-called average risk for colorectal carcinoma, which is, basically the general population, the recommendation is to start screening with the tests that we've talked about. One of those tests, and by the way, colonoscopy is certainly the most definitive test, because you can then identify the polyps, and not just identify polyps, but actually remove them. Bear in mind, if you detect a polyp or suspect a polyp with the other test, you still have to go back and do the colonoscopy to remove the polyp. So again, start at age 45 and end at age 75. At age 75, then it's a question of judgment on the part of the doctor, judgment on the part of the patient, maybe the family. If, let's say, polyps were found in somebody who's almost 75 or somebody who's 75, well, it makes sense to continue to screen, I would argue. That's a question of judgment. And then another caveat or exception would be people who, for some reason, have not been screened until they were almost 75 or 75 even. Then comes a question of judgment. It probably makes sense to screen them at least one time at that point. And then in that second bullet point, you can see that high-risk patients, we start screening 10 years below the age of the youngest family member with colorectal carcinoma. And that, I think other speakers will speak a bit more to that, but just to elaborate, a significant family history of colorectal cancer is in families in which somebody a first-degree relative means a parent, an offspring, or a sibling. A first-degree relative who has developed colorectal carcinoma below the age of 60. So at least one first-degree relative with colorectal carcinoma below the age of 60, or two first-degree relatives at any age, including above 60. And then that becomes a significant history. And in that case, you look at the age at which the youngest age at which a first-degree relative developed colorectal cancer. If that age was, let's say, the youngest age at which one of those relatives had colorectal cancer was 48, you have to start screening family members 10 years before then, 38. If somebody developed, if the youngest age was 42, you have to start at 32. So quite an exception. And then there are other more rare syndromes. In fact, in some of these syndromes, children have to be screened, but I think other speakers may speak to that. Okay, how often do you do these tests? So I told you colonoscopy is a superior test in that it's the most definitive. Its frequency, by the way, this frequency refers to if no significant polyps were found. There are two types of polyps. There is the hyperplastic polyp, which is completely benign, does not even develop to colorectal carcinoma. So if you find such a polyp, hyperplastic polyp, or if you find no polyp, then colonoscopy can be done every 10 years. If you find an adenomatous polyp, that is the type that develops into colorectal carcinoma. And depending on the size, you'd have to repeat the colonoscopy much more frequently, and other speakers will speak to that. But I'm here to mostly speak about your typical average case. In this case, this slide is referring to people in whom the screening test was either completely negative or at the most a hyperplastic polyp was seen, which is the kind of polyp that does not develop into colorectal carcinoma. If that's the case, then colonoscopy can be done every 10 years until or unless you see a significant polyp. The FIT test, which again, remember, is a test looking for human blood, can be done once a year. The CT colonography, remember, is a CT scan with reconstruction, virtual reconstruction using software of the colon. That can be done every 5 years. The GFOBT, which remember is a test looking for blood from any animal, human or otherwise, that's also once a year. The FIT DNA, which is looking for blood and for altered DNA, so a more sophisticated way, which include altered DNA, which is consistent with cancer or the early developed or precursors to cancer. Now that can be done every 1 to 3 years. You can see that you can get away with doing that less often than just with the pure, test looking for blood. Next slide, please. And if you'll permit me to talk a bit more about Duchess International Hospital, I think this is important. There are a lot of Nigerians on this call, I do believe, and non-Nigerians, please forgive me. Nigerians and maybe even non-Nigerians too need to know that in Nigeria, a number of hospitals have been developed over the last 10 to 20 years, which are of international standard. And here we're talking about screening for colorectal carcinoma at Duchess International Hospital, where I'm privileged to be the medical director. We do 3 of these screening tests: colonoscopy, CT colonography, which, as you know, is a CT scan which reconstructs the colon virtually, and then the stool fit test, which is superior again to the GFOBT. Remember, this is a test looking for human blood in the stool. However, it's not the one that looks for DNA. Okay, and then Duchess Hospital, we state that it's a state-of-the-art facility. For example, we have a 64-slide CT scanner. We provide qualitative treatment. We pride ourselves on our strong governance and that we have access to world-class consultants from all over the world. Next slide, please. And these are some of our services. It's a multi-specialty hospital. Next slide, please. And we pride ourselves on, again, not just the fact that we have the strong commitment to quality, but we do emphasize screening, including for colorectal carcinoma and other diseases as well. We have a 1-day screening process, and we also have a 3-day screening process, which is kind of upscale, including special spa treatment at the Marriott Hotel, which is less than which is about a kilometer away. but we have the more regular screening as well. So including screening for colorectal carcinoma, cervical carcinoma, breast carcinoma, cardiovascular disease, etc. And I think okay, and then very good. Well, this last slide speaks to some specialized products that we have. This is where we're able to have specialists from all over the world to consult with our patients, both on an outpatient and an inpatient basis. And with that, I thank you very much.